Good afternoon, everybody. This is Jason Belden with the California Department or California Association of Health Facilities. I almost thought I worked for the state for a second. Um, Kidding, very much kidding. Today is May 8th, 2020. It is 1 o'clock Pacific time. We're meeting for our weekly roundup. And today with me, you're not seeing a repeat of last week. We have Stan with us again, and he's going to talk a little bit later with some other issues to cover on the 1135 waiver for the life safety code. Well, that's me, hosted by Jason Belden. This week, we're going to talk about things like infection control, fit testing, media and what that looks like, and then we'll talk about the 1135 for the life safety code, and then we'll get to what we anticipate coming down the line. And I want you to stay tuned for that because it's going to give you some things that you could probably start on now to get ahead of what we anticipate coming from Department of Public Health. All right, so what happened this week? It's weird that we have to have a webinar every week to cover AFLs, but they're coming fast and furious, and this is just one of them. But this as it relates to testing. This is kind of a new guidance document, and this is essentially where we anticipate everything to go. I talked about this a little bit last week about what the likelihood of you having to test all of your staff and employee or staff and residents were. I think this week it's becoming even more clear that that is not just going to happen in areas that have bigger outbreaks. I think it's going to be broadly applied for the entire state, but we'll get to that in a second. So essentially the kind of testing they're looking for is to test everybody. And these are the folks that they say are going to take priority in terms of testing healthcare workers, first responders, and other social service employees. We're going to screen, obviously, all asymptomatic residents, but we're also going to probably end up testing those folks as well. And then there's going to be notification requirements. They're listed out in that AFL. But one of the key issues that they've identified as being a priority, and this one is really important to us, and that's one of the things that we have asked for since the inception of this activation, and that's to test every admission and readmission from a hospital to a facility. We've heard cases, anecdotal, about folks coming from an acute without being tested for COVID, not having any symptoms, and then turning positive while they're in the facility. We've got enough cases that we know that this is one of the vectors for the virus to come into our building. So I think we finally got some traction on getting these folks prioritized first in line for testing. So we will look forward to that rolling out and that happening. I don't know if you guys saw this or had a chance to join, but CDPH had been doing calls with, I guess, on a regional basis for infection prevention, but now they're going to do a statewide call. They're going to hold it every Thursday from 12 to 1. That's the phone number and the access call. Whoever works does infection prevention at your facility definitely needs to be on those calls. A lot of it is a repeat of information we already know. A lot of it is a confirmation of things that we're currently doing. So those are all good to get to know that you're on the right track. But I think as things change, and maybe things will change in a week from now, this is going to give you access to the most current information from a hospital-associated infection branch at CDPH. This is not a licensing program. These are the folks from the hospital-associated infection, and that's all, or healthcare-associated infection branch, and that's all these folks do. They're not a part of the licensing branch. After listening to the call yesterday, they had some good information, maybe information that you have not heard before. And then a lot of repeat information reinforcing things that we know you guys are already doing. Nonetheless, I think it's good to just maintain our situational awareness and make sure we're on those calls and have our IP person on those calls as well. All right, so what were kind of the highlights of those things? And when I say stay the course, hopefully, and I assume that the vast majority of you guys are already doing the staff screening at the door. I don't have to tell you about having to do that, but it is an active process and somebody is monitoring that and they're documenting it. That needs to continue to happen, and we don't know when that's going to change, but even though there is asymptomatic transmission, there are still folks that come slightly symptomatic. And one of the good things, one of the good recommendations I heard from them on the call yesterday was, you know, those symptoms that they list out as being these symptoms are not, it's not 100%. So there could be other underlying things, a general feeling of malaise, you know, other issues like that that could be causing that. So I think her recommendation was be conservative when you do your query of the staff as they come in, and when they come in, if they're not feeling okay, have a process for, well, we're definitely gonna keep these folks out, but what does it look like when I need to replace the staff? Hopefully we've already got in our mind how we replace staff as a part of our normal, you know, protocols when somebody calls out. That should all still continue and things like that. The documentation can't be stressed. I can't stress that highly enough, not just in this, but documentation as you go through the response of this. Whenever you see an AFL or a guidance document from CDC or CMS or whoever it is, or your local public health department, we want you to print those off and keep them in a file. Keep an idea of when things are changing and as they change. I'm not saying, you know, get prepared to be sued, but I'm saying that make sure that the documentation you keep aligns with the plans that you have. And so as documentation changes and recommendations change, your planning process has to have that dynamic of being able to take information that you're learning on an almost daily basis and use that to effectively implement changes in your plan to incorporate that new information. That dynamic planning process applies broadly across anything that you do. And so when we talk about documentation, it's not just this, but in this case, we know that that CDPH is going to be looking at that you're documenting this stuff, meaning documenting those symptom checks of the staff before they come in. They also talked about, you know, in environmental controls and source control. And environmental controls meaning you have one designated entrance or two designated entrances. And at both of those entrances, that's where those folks are doing the symptom check. Source control just means, you know, one, all of the healthcare workers, all of the staff, we're wearing masks. And to the extent that the residents can tolerate wearing a cloth mask or some other form of source control, that is encouraged as well. And when we talk about social distancing, that's not just outside of the building, but that's inside the building in areas in which we congregate. Break rooms, things like that. We've got to look at maybe staggering out how we do breaks or things like that. Think of creative ways to maintain that social distance. Gosh, you can make a joke out of it and tie hula hoop around you or something. I don't know, but just a visual of how and what that looks like. I know I don't, you know, I haven't had to leave my house much because we're sheltered in place at home. But when I've gone out to places, I've seen some places which have little dots on the ground which indicate 6 feet apart from other spaces. And as we talk to people and we talk to our staff and we have meetings like that, I want you to think of those visual spaces that we can maintain that distance try to the extent possible, keep folks at a 6 foot distance, even while we're practicing source control. We want to limit exposure. So how many times do we need to go into an actual room where we're required to wear full PPE? And are there things that the care worker or licensed staff or whoever goes in there could also do terminal cleaning or do cleaning of high touch surfaces while they're also in that room? So it would prevent EVS staff from having to go do a cleaning for that. So that's one less exposure. It's thinking about our procedures in providing care with the folks and limiting the amount of time that we could potentially expose those residents and staff as well. More frequent cleaning of high touch surfaces, that goes back to all of it. One of the good pointers that somebody from the HAI branch talked about yesterday was just ask your staff that goes into the resident rooms and put a sticky note or a tab or something on the 6 most frequently touched surfaces that they touch in the room. Just think about it, visualize it, put sticky notes on it, and those are the ones we want as frequent a cleaning as we can possibly get. I know this second to last bullet point is incredibly difficult to do, especially the staff part. But if we can, we need distinct space, distinct staff, and distinct supplies if we're going to take COVID into our buildings. That's everybody, every administrator I've talked to that's currently doing this has all talked about. This is the nuts and bolts of how we keep this out of the remainder of the building, is by essentially having a space within a space. And all of this needs to be not an esoteric thought in your brain. It needs to be written out into some form of a plan. And I'll talk about the elements that you're probably going to need to put into that plan if you've not already as we get to the end here. All right, give me a second here. Okay, so we've received some conversations with providers that have had folks from Cal OSHA inspectors in the building. And when we looked at the original waiver and the guidance from Cal OSHA, it seemed to allow for us to use surgical masks in lieu of N95 masks if we could not get N95 masks. And I want to reiterate that still appears to be consistent. But the nuance here is if we have an N95 mask, they're still required to go through the initial fit testing process. And so many of you have some of your staff that have gone through that initial fit testing process. So we know that it's not as easy as just making sure that the healthcare worker can get a seal check on the N95 mask. It goes beyond that to do the initial fit testing, and that is a part of a model respiratory protection program. It comes with training, it comes with medical clearance. There's a number of things that go into the initial fit testing. Our plan, when we saw the waiver waiving fit testing, and we saw this allowance for using surgical masks if you didn't have N95 masks, we did not see that there's a gap in between those two, and we need clarification from Cal OSHA. We think it's been pretty clear that we have not been given a choice as to whether we take COVID or not. If COVID has entered our building, we've not been given the choice to evacuate all those people and not risk our folks that aren't fit tested. So we've not been given the opportunity, I think, to succeed. So our plan is to talk to Cal OSHA on Monday, and our hope is that we can get some clarification. My guess is I think this was a blind spot that nobody had really thought of. And it's quite possible that Cal OSHA thought that there was some requirement to have every one of our staff fit tested, and that is not has not been a requirement. It may be going forward, but it's not now. So it's things like that. There's a disparity between what the folks in the state think is possible in our buildings and what can actually occur. I do know there are a number of providers that have found mobile fit testing solutions or other kind of vendors that could come out and do fit testing. We'll get confirmation on whether those meet the intent and the regulation of the initial fit testing, because it does not include a model respiratory protection program or the initial training or the medical clearance. But we can do the actual physical part of fit testing it to a make and model. And that brings me to the second part. Fit testing is specific to a make and model of N95 mask. And so when we talk about fit testing, it's not just an N95 mask that you can tolerate wearing. It's that seal is dependent on a specific make and model. Now we all know that for most of us, or for a lot of us, getting those resources and getting the sizes and the make and model we want can be difficult. I think we'll slowly work our way to being able to get those supplies, but maybe I'm wrong. Maybe you guys have access to these, but I'm under the assumption that we're still far, far behind the curve on getting our PPE supply and the supply chain back up and running to do all these things. So what we have been encouraging folks, and what we think you should do regardless, is have somebody that is rock solid on donning and doffing. Have that person work with the staff that you think have challenges donning and doffing. Even if you don't have COVID in your building now, I think it's appropriate to assess the comfortability that your staff have with donning and doffing, and it's really important. The seal check is obviously important. That is what prevents those particles from entering the mask. And then the doffing procedure, where we're taking off dirty PPE, is another really common exposure point, because you're taking dirty stuff off. And if you do it, you could do it incorrectly. You could contaminate your existing clothing, or yourself, or something like that. And then the last bullet point: surgical masks are allowed under that Cal OSHA guidance if no N95s are available. But like I said, there is still that disparity of the initial fit testing, whether we're going to get that waived or whether that was just an oversight on everybody's part up to this point. So what happens if you get a Cal OSHA inspector in the building? Well, we know that workplace injuries need to be documented. There's a form, a Cal OSHA form, you need to document that. I know some folks have asked, how quickly, how soon do I have to provide that information to Cal OSHA? Well, we're going to get that information and all that information for you. If you've not subscribed to the forum, I plan on putting a detailed description and whatever resolution we come to with Cal OSHA on the forum. If you're not signed up to receive those updates from the forum, I suggest you send an email to info@caf.org. And if you are a CAF member, give them your email address and the facility that you work at, and they'll happily add you onto the forum list. And that way, we put things that are time sensitive on that forum as we get them. So even if you've not subscribed and this is maybe not interest you, there are a lot of things that we put on that forum that could be of value to you. All right. So I know this is a new thing that has come out. The CDC reporting is separate and distinct from the CDPH reporting. And I know we've worked tirelessly to try to get CDPH to incorporate this into one kind of broad survey where they could do the the data entry part of separating this out into what goes to CDC and what goes to us. Unfortunately, the way that program works, I don't think it's set up. I don't even think if they wanted to, they would be able to do it. I'm not certain about the technical aspects of it, but I can say that our advocacy up to this point has led to, well, frankly, no results. We've only got CDPH and CDC to do their own. We've not got them to combine their efforts. So what needs to go into that CDC reporting? Suspected and confirmed COVID-19 infections. That's obvious. Total deaths and deaths divided out among residents and staff. Personal protective equipment and hand hygiene supplies in the facility. This is a question that's going to be on the survey. Obviously, it's not going to apply to most folks, but ventilator capacity and supplies in the facility. They're going to ask for, how many total beds you have and what your current census is. Access to COVID testing while the resident is in the facility. I believe that's more of a yes or no question. Are you currently experiencing staffing shortages? And I think we've got to be, I don't know that you want to hold back, information on the staffing shortages. I think it's important to document that our staffing shortages are not just in the facilities that have COVID positive people. They're in all the facilities. And so if you guys have moved to an alternate staffing model, I want you to, to acknowledge that. It's clear that folks just don't understand how difficult it is with staffing right now. And maybe you're in a part of the state where you go, oh no, I'm great, and hey, great for you. But there's a big portion of the state that is really struggling. So even if you're not in a COVID positive building, if you're suffering from staffing shortages, I highly recommend at least making sure your voice is heard there. There was some question about whether ICFs would be required to do this reporting. I'm happy to say that we looked at the Federal Register, and the only folks that are going to be required to do this are the skilled nursing facilities. And there are 2 F tags that will now be assigned, and you will be cited. You will be cited for noncompliance if you don't do these surveys. So there's a penalty for it if you don't do it. There are F tags, 2 F tags associated with noncompliance. These are meant to be done at a minimum on a weekly basis. I don't know how complex the process is because you have to go back in and sign it. It looks fairly, the process to sign up looks like all government stuff. It's more complex necessarily than it needs to be, but there is an email address, and I recommend reaching out to those folks to ask for assistance going through it. Patty put together a guidance document that we sent out by a magnet mail 2 days ago, I think, or maybe yesterday, that describes the process of how you log in, how you sign your account up, all of that stuff. So look in your email for a magnet mail from CAF about that. And I think a link may even be posted to that on the website, but I'll have to go check, double check that. All right, so what do we got next? Media relations. Oh gosh, one of my sometimes least favorite things, and sometimes it's good, but I will say that we have heard without fail, anybody that's had COVID in the building, most of the providers have had some media attention, some more than others, obviously. But what we're even finding out is there are buildings without COVID in it that are getting media attention. We've seen staff, CNAs or other care staff walk off the job and have a press conference in front of a facility because they didn't feel like they were getting adequate PPE. We've had the media show up at facilities because they were wrongly identified on the survey as having COVID outbreaks. So whatever your situation is, if you've not already had media attention, I think it's time to at least put something in your pocket and have it ready to go if you do have the media show up on your doorstep. So what that looks like in a Cliff Notes version, you want to have a designated person for each media contact, and then a family representative, somebody that can reach out to the family. Let's say you have an outbreak. You're going to need a dedicated person to just do a messaging with the families. It may even require more than that, more people than that. But definitely have a plan with somebody identified and say, okay, you're great with families, or you're great with communicating. Are you okay with making these calls to family or being the point of contact for families when they call in with questions? So that's one. And the other one is more of a media thing. And this could be somebody internally. It could be somebody externally. I know a lot of facilities, especially facilities going through an outbreak, may seek an outside public relations consultant or a media consultant. Certainly within your wheelhouse, if you have the financial resources to do that, that would probably be a best practice that you could model. But what I would probably not do is I would not have the facility administrator being the media contact, simply because one, your time is very valuable, and two, we want you to develop messaging, and we want the folks to stick to that messaging. And then if you have questions about public relations, how you should talk to the media and things like that, we want to do that in a methodical and thought out way. And you want to do it in a manner that's not going to compound the issue or make you look poor in front of the media. And so if you have questions like that, if you're a CAF member, CAF has created a great toolkit that's available on the member only section of the website that you can go to. But the things that they talk about are these: they're designating a person for each one of those things, crafting the message, and having that ready to go. Your front desk staff needs to be able to have those canned messages, and they're the ones that you hear. You like, we prioritize the life and safety of everybody in the building. Our administrator would like to thank you for reaching out and asking for us to be interviewed. At this time, we're not, this is a prepared statement or whatever. Just think about that messaging and how it goes to your front desk staff. This is kind of a best practice, but if you can do it, if you can have a phone line solely set up for the families, and that's it, that's the only people that call that number. If you have an internal line that maybe you could dedicate to that. I know we have lots of folks on a VoIP, so if you've got a VoIP system, they could add a phone line into that pretty easily, or add another phone line to that. So those are all things that you can think about. And then the last part is really critical, so you don't have those folks out front of your building talking to the media, is let all staff know to coordinate messaging through whoever your designated contact is. And that's, I think, just as important as we go forward. Those are bad messages that the media hears, and it gets amplified because there's not a lot of people on the other side going, my workplace is fantastic and my employers are providing me all the PPE in the world. So we want to make sure that we're not compounding the problem. And a part of that's going to be relationship building with your own staff, and have you talk to them about the realities of what we're facing, and be honest with them, and also talk about the risk and everything that you're going to do to help them protect themselves. I think that's important, that they know that you're in this with them, and that you support them, in any way, shape you can. Sometimes I feel like maybe they're not hearing that. And then sometimes I think they're closing their ears to that. So what do we want to cover on 1135 waivers? We asked Stan to come back for a few minutes to just talk about the 1135 waivers as it relates to life safety code, and then we'll talk about next steps and what we see coming in this following week. Stan?
Thanks, Jason. Can you hear me okay?
Yep.
All righty. Yeah, the 1135 waivers. We got some good news last Friday, something that we were waiting for and something that we referenced during my life safety presentation a couple of weeks ago, where we talked about strategies on how you can navigate life safety compliance in your building in consideration of COVID-19. We referenced the fact that we were hoping the 1135 waiver would be issued, and fortunately, when you guys were doing the call last week and we had addressed life safety the week before, we got that notification from CMS that the waiver had indeed been issued. So go ahead and advance one, Jason. The 1135 waiver is a blanket waiver. So all of our providers on the phone are pretty familiar with this, even though our skilled nursing facilities that are surveyed and regulated under CMS guidelines all have a policy and procedure in place on how to apply for a waiver. The good news is there is nothing that you need to do here. The waiver is a blanket waiver. It is a retroactive to March 1st, and it gives you some relief in the inspection, testing, and maintenance of some of your critical fire and life safety systems. I apologize, but the header says IMT when it in fact should say ITM, inspection, testing, and maintenance. Now, it's not a complete get out of jail free card. Like we talked about during our webinar a couple weeks ago, you know, life safety is critical in your buildings, especially when you find yourself in unusual circumstances where you're in an official shelter in place mode, where your emergency operation plan has been activated. This doesn't really vary from the strategy that I suggested last week, where I still am going to promote that if you haven't done it already, you still go ahead and add some language into your policies and procedures as well as your EOP itself that basically says that under emergency conditions, we may not be able to comply with all of the life safety requirements in strictest conformance of those regulations. But the waiver, the blanket waiver, and I'm just going to read this verbatim, gives you some relief from a regulatory and survey perspective. CMS is temporarily modifying these requirements to the extent necessary to permit these facilities, that's probably all of you on the call today, to adjust scheduled inspection, testing, and maintenance frequencies and activities for facility and medical equipment. So that's a pretty broad statement, and that should be giving some comfort to many of you that have been struggling about the fact that you don't want maybe certain vendors in a building, or if you do want a vendor, like your sprinkler contractor in the building, and he or she tests positive during the screening process, well, we of course know that you're not going to let them in the building. But first bullet point addresses activities and medical equipment. What would be an activity that we could think about? Well, you know that you've got some life safety activities that are prescribed in the code, one of them being, for example, electrical outlet testing. You all know in the care center environment, in our skilled nursing facilities, that if you've got electrical outlets and they are not hospital grade outlets, you've got to do annual testing of your electrical outlets, which includes voltage and polarity and tension testing. Most of you do that in-house. Most of you have a spreadsheet that you keep an inventory of those outlet tests. You've got a work order process to correct anything that's out of compliance, etc. So let's say that in the middle of the second quarter right now, it's up for you to do that particular process, and clearly in accordance with this blanket waiver, you can defer that. You cannot eliminate that. You can't say, well, we're in the next quarter or we're in the next half of the year. We're just going to go ahead and forget that we did that or forget that we didn't do that and just bundle it with our next. The expectation is that it is going to be completed, but you have got some some flexibility in frequency and the specific activities. Another thing would be PCREE. You know that you've got a policy and procedure in our nursing homes to do periodic testing of patient care related electrical equipment. Let's say that you've done a repair or you've done some type of alteration to a system or equipment, you can defer that particular task. Second bullet point, CMS is temporarily modifying these provisions to the extent necessary to permit these facilities, again, you, to adjust scheduled inspection, testing, and maintenance frequencies and activities required by the Life Safety Code and the Healthcare Facilities Code. The following are considered critical and are not included in this waiver. So these are the exceptions. If you've got a motor-driven or an engine-driven fire pump in your building, let's say that you're a multi-story facility in the Bay Area, you're right in the heart of San Francisco, and you've got a fire pump that's operated by a diesel generator or an electric motor, you still must do your monthly testing of that equipment. This one makes total sense. You know, you're sheltering in place, you've got unusual circumstances. Why would we waive your internal requirement for you to do a monthly inspection of your portable fire extinguishers? That's your first tool. That's one of your major lines of defense. So make sure that you do not deviate from doing your internal visual monthly inspection, whether you keep it in a computer database, whether you use the tag itself to check that you've done that monthly inspection. Portable fire extinguisher monthly inspections are not covered by the waiver. Back to our multi-story facilities. If you've got an elevator that has phase 1, phase 2 operation, that means that when the fire alarm sounds or certain detection devices are activated, your elevators will recall to a specific point or an alternate point. If the fire is at that specific point, you've got to test those functions. Phase 1 is the recall function. Alarm sounds, elevator is recalled. That is phase 1. Phase 2 is when the good guys, the fire department, gets on the scene. They take control of the elevators with the keys that they have in their Knox box or the lock box, and they utilize the elevator in a modified fashion under emergency conditions. You've still got to test your elevator functions. Your emergency generator, 30-minute continuous monthly testing and associated transfer switch monthly testing. You've got to continue to do your monthlies on your emergency generator. And again, I'll state the obvious. It only makes sense that you do that. That generator is the lifeline when the power goes out, so make sure that you're up with your generators. And then finally, I'm going to expand upon this a little bit. Means of egress daily inspections in areas that have undergone construction repair, where you can see that I underlined alterations or additions to ensure its ability to be used instantly in case of emergency. For those of you that were on the call a couple of weeks ago, you might remember that one slide that I had that showed a really nice partition that was created in the center of the hallway to segregate the building, to keep people out of certain areas, basically to kind of create an isolation barrier. If you go ahead and do that, you remember that we stated that you've got to develop an alternate life safety measure, or for people that are accredited by Joint Commission, it's referred to as an interim life safety measure. But part of that alternate life safety measure is that you do daily inspections that are documented of the means of egress in consideration of these barriers or things that are in your building. Some folks have gone ahead and integrated a very formidable type of barrier that includes a door, an exit sign. Maybe you've added an extra fire extinguisher because the barrier is going to compromise access to an extinguisher from one side or the other. Or maybe you're a little bit more basic. Hopefully you just haven't slapped visqueen up or plastic sheeting over your smoke and fire doors, but you've created some kind of barrier, maybe taped it to the wall, you've put a zipper in it. You know what I'm talking about. If you've got those alterations to your building, one of the things that the 1135 waiver is not addressing is the fact that you still have to do those daily inspections. Document them and make sure that the conditions are as safe as possible. Jason, the last thing I wanted to talk about is ABHR, alcohol-based hand rub solution. If there's one common call other than fire drills that I'm getting most frequently, people are calling up, and I just took one from a provider up in Washington State where I did a similar webinar for them earlier this week. They got a donation, a 30-gallon drum, a couple of them actually, of ABHR solution. They wanted to know about storage. Can they put it in their basement? Can they bring it in their facility? I just want to remind you that, that's a 95% or up to a 95% concentration of alcohol. Think about the dangers of those flammable liquids in your buildings. They're allowed under certain prescribed conditions, but let's just be awful careful. And at the very least, think about getting a flammable liquids locker. Here's a sad residual of what we're living through right now. And I just counseled somebody on this, similar to the downturn in construction that we saw in 2007, 8, and so forth. Some construction material or equipment like flammable liquids lockers are becoming readily available for pennies on the dollar. So if you want one of those flammable liquid lockers, you want to be a little resourceful, go on eBay or one of those types of sites. You could probably pick up a $2,000 flammable liquids locker for maybe $150 or less. So with all that, Jason, is there anything else that you want me to cover or we didn't address?
No, I think that was it. And Stan's going to hang out for a second. He has to drop off a little bit early, but if you guys have life safety questions, please put them in the questions box.
All right, that's it for me then, Jason.
All right, perfect. Thank you very much, Stan. So I want to talk for a second before we get to the questions part. I want to talk for a second about what we anticipate that could potentially be coming from the state. I know last week there were some folks that were maybe a little unclear about what I was saying in regards to testing. We want to encourage you guys to testing. Simply, I know it brings with you a host of problems, like what the heck am I going to do if I spike 30 cases or 10 cases or whatever. We know that is an issue, but if the ability of us to take that knowledge that we have of who those people are and we can cohort them or whatever your plan is to deal with those folks, the known COVID patient is much easier for us to plan and operate around rather than the unknown. And the unknown is a big part of what has driven some of these large outbreaks. And had we had instant on-site testing, gosh, we could fix a lot of this. That is not on the horizon, at least that I know of. But I think what is on the horizon, and we know that some counties have already prescribed this. They've already said that you must test. I think what's likely, I don't know this for sure, but I think what's likely is in the coming week, we're going to see a state requirement to test everybody, or something similar to that. And we don't understand how that's going to happen, whether it would be done through public health labs or would we have to use our existing lab partners. We've argued with folks that the testing at a private lab has limited clinical value if we don't get the results back for 7 to 10 days. And so we need a quicker turnaround in order for it to have value for us. And so we're going to work with CDPH on advocating that we be first in line for all testing through public health labs or whatever labs that can get the quickest results. That continues to be our advocacy efforts. Some counties will be able to accommodate that, many will not, just based on the numbers of facilities. If we say we got 1,200 facilities in the state of California, and you figure on average, maybe a county might have 4 or 5 public health nurses to go out and do the testing. It's a real, kind of bottleneck to rolling this out broadly across facility. I do think a measured approach is good for the counties. So we're not taken surprised by 20 facilities that have outbreaks unknown. But I will say that you know, we need to think about how we're going to accomplish this ourselves if there becomes a requirement from CDPH. And that's not just how am I going to test everybody, but it's also maybe thinking about what it's going to look like for surveillance testing in your building going forward. We're going to continue to do all the same mitigation strategies we're already doing, but now we may be asked to do a little more, and testing is part of that. We've asked you guys a bunch of times to, write out your plan for cohorting and what it looks like. Who's going where, how often you're going to be reevaluating the people in the building if you have an outbreak. Because it's not just test them once, it's test them, and then we're going to have to keep an eye on the folks, even the ones that have tested negative. It's not 100% on the results, so we need to at least be cognizant of that. That's surveillance, that's temperature checks, symptom screening, all of that stuff that we're currently doing needs to continue even after somebody comes back negative if we have an outbreak in the facility. And then we're gonna screen everybody for symptoms, have their vital signs monitored, things like that. There are a lot of things that we're going to have to plan out. And my assumptions at some point is CDPH or possibly your local public health department is going to want to see your plans in writing if they've not already asked for it. So prepare to not only have it, but to be able to provide it to them if they've not already asked for it. The other things that we hear talk about, and I certainly heard it on the call yesterday with the infection prevention call, was this encouragement to have a dedicated infection preventionist in your facility, and not, I know it's a requirement of the rules of participation that we have somebody identified to do that as a lead, but I think probably something coming that it's possible that could highlight the infection preventionist role or expand their role in helping your response to COVID-19. So I think that could possibly come. I want to talk just for a second about the acquisition of PPE. And I don't want you guys to have to do another survey, but my assumption is that our supply chains have been restored up to whatever our historic level was. In other words, if we would order in from McKesson or Medline or somebody else, and we had normally ordered X number of supplies, our assumption is that particular bucket is now being filled. Please let me know if that's not the case, but that has been filled. We've told the state that even at 100% of our historical averages, we're still 2,000% over our burn rate over what our historical averages were. Where are we going to get these supplies? And it's not even a matter of cost at this point. It's a matter of location. I don't know where they are. And we passed out unvetted vendors and everything else. But I think there's going to be an increased focus on you being self-sufficient to supply your own PPE. So please be a vocal voice and let me know if that does not sound like an even realistic proposition to you. Even after we submit our resource requests to the state and things of that nature, the expectation is during that process, we're still continually trying to meet our own needs. And so I know CDPH sometimes does not see those efforts that have gone into that, but definitely let me know if there was something that came out that said you're required to have X number of PPE on an ongoing basis, whether we think that's realistically achievable or not. All right. And then kind of the last thing that we really want to talk about is as it, as it relates to what we think is coming. We know that staffing shortages are acute, and then especially if you get an outbreak, they're going to be even worse. We want to encourage you guys. We know you have a plan, an emergency operations plan, and generally a part of that emergency operations plan has an alternate staffing kind of model. Hopefully you're already in that, or if you're not, use that as your first line of defense. Call staff callback, moving to 12-hour shifts if you absolutely had to, things like that. Expiring those staffing registries. I know I've heard, the cost of registry nurses is exorbitant. I mean, it is, when I looked at what the rate somebody was paying registry CNAs, I about quit my job and went to go work as a CNA. That's how much money it was. And it's a lot, but the expectation is that we expire all available private resources before we reach out and ask for staffing help. And I know I can be firm or sometimes gruff about how we do this, but the expectation from the state and from the public is that we have a plan to be self-sufficient with our own resources and with the resources of private industry before we reach out to the state for help. Now, whether that's fair, whether we're being adequately compensated for it, those are all things that are very real arguments that we make all the time with CDPH. We will continue to do that advocacy ad nauseum. We will not take a break. You guys aren't taking a break. We're not going to take a break. We're going to be here and do everything we can. So I want you to guys, please don't be mad at the messenger. I just want you guys to be as prepared and ready to go as possible if this happens to you. So if we could, I know I went a little over, maybe we could respond to some questions. Courtney, do you have any questions in the questions box?
We got a few. Can you hear me okay?
I sure can, yeah.
Okay. So we have a couple questions about testing. So I'm going to combine a couple of these. Let's see. So a couple of providers asked, if we do get testing, how frequently do we need to be testing staff? Every 2 weeks, once a month? And what about antibody tests for asymptomatic staff?
That's a great question. And I don't even think we've, us and CDPH and the folks at HAI, well, the folks at HAI probably have thought past this, but we brought it up on a conversation. I think the original goal, the initial goal of the state and everybody is to get everybody tested at least once. And then the process for surveillance testing, we'll need to figure that out. And right now, I don't know that there's a best practice because we don't have any models to really look to. So for now, we're going to concentrate on the initial testing. And then I know Los Angeles County has talked about how frequently they want to do surveillance testing. If it comes out as a guidance from CDPH, we'll ask them to define the measure in which they want us to meet or they think is best practice for surveillance testing. But as of yet, it's not clear and I don't have a good answer for you. Next question.
Yes, we have a question about fire drills. Will the fire drills now be waived with the outside vendors?
Yeah, the answer is pretty clear, no. Fire drills are still required. Fire drills are not one of the tasks that are covered under the waiver, which specifically focuses on inspection, testing, and maintenance protocols, but fire drills have to continue to be done. The flexibility that you have, especially if you're not allowing vendors in or if vendors can't get in, you could still do those fire drills regularly on your own. You could think about, especially in the midst of the quarter that we're in right now, second quarter, wait until the end of the quarter, which is the end of June, to do any of your fire drills. Manage those drills that you do at least 2 of your drills, second shift and knock shift, between the hours of 9 p.m. and 6 a.m. That way you don't even have to sound the fire alarm. You do have some latitude in your fire drill scope and function, again, provided that you add language to your EOP or your policy and procedures that states that you need to vary the drills under an emergency condition, but you are not absolved from conducting those drills. As a matter of fact, we think that you'll probably be more held to a higher standard if you fail to do the drills in the midst of a pandemic.
Okay, next question. How is testing going to be enforced by the state during a time when they have clearly stated they are only enforcing immediate jeopardies and abuse type situations? And what do we do with our staff or residents that refuse to get tested?
Yeah, I still haven't gotten an answer on the refuse to get tested part. We haven't got to the point where the state has mandated it yet, but I'm reading the tea leaves, and I want you guys to be prepared for when that happens. I don't know that yet, and that I'm certain if if there is a question about what happens if somebody refuses a test, that will be a part of the conversation we have with CDPH, because it's a very real thing. There's going to be I've talked to a number of people that said, well, I'm not going to do that. So not administrators. I'm talking to frontline staff that are they're going to refuse to get tested. So we'll get clarity on that before anything comes out, or we'll ask them to clarify that in any AFL or any policy. Next question.
Let's see. Well, so for the question that we just asked, did you have anything to add to how is testing going to be enforced by the state when they are only doing IJs in abuse type situations?
Well, I would assume it would be, they would write it in, and they would come up with a survey deficiency for it. It could be an IJ, it could be something else, but it's going to be, it's going to be so onerous that we're not going to really have any choice as a provider. So it's either going to be test or a really bad option. That's my feeling. I don't know that for sure, but I imagine something like that would happen. If you refuse to test or refuse to have testing in your building, we're probably going to get an IJ. Next question.
Okay, question. Staff need to renew their CPR certifications. Is there any waiver on these?
That's a great question, and not something I've heard before, but I will find an answer for you, and I will address that on the next webinar. That
Jason,
I don't know. Sure. Yeah.
Don't hold me to it, but I am pretty sure that you're going to find that there is some relief there under the blanket waiver, but you need to get confirmation for sure.
Yeah.
But I think I did see something about that.
Yeah. I apologize. I don't have the answer off the top of my head for that. Next question, Claire.
Regarding reopening Snips for admissions and visitors, is there a plan coming out when and how this will roll out?
I don't see that happening anytime soon. I really don't. I think visitation, as it used to exist, is going to be done for a while, and we really well. I'm certain that most of you guys have thought of creative ways to help the families communicate with their family members. Continue that, because I don't think, or expand upon that actually, because I don't foresee that going away. That as a vector for how this comes into the building is very real, and I don't foresee that changing for a while. Next question.
Do we know if the governor will be signing the bill to protect Snips?
That is $1 million question, isn't it? It's not. Every time we talk to everyone at Health and Human Service Agency, that is our number one ask. And it's not just our number one ask, it's the ask of many other healthcare associations. So we feel like we've not been given a choice to take these folks, and we were put under impossible circumstances due to a combination of factors, including PPE, poor infection control guidance, lack of adequate testing. There are a number of things that have gone into this. that have been outside of our control. And as we explain that to the governor, we can't be held liable for things that were out of our control that we had no ability to control. Now, I don't know that that's the case 100% of the time, but I do know that's the case enough of the times that for administrators who no fault of their own, through no poor infection control practices or anything else, were blindsided by this virus coming into their facility. And that has to be addressed. And it's a part of our message every time we talk to them. And we talk to them frequently, many times a week. And we know it's a real serious area of concern. Unfortunately, I don't have a good answer for you. And whereas I was a little more optimistic previously based on the other states that had a similar size and political makeup, that we would be successful, but I don't think that has, well, I don't want to say that. We're still trying and we're still actively trying, and it's still maybe our number one focus, but how effective we're going to be on that advocacy, I don't know, but we're trying everything we can. That is extraordinarily important for us. I just want you guys to know that. So I want to be cognizant of folks' time. I know we got a bunch of other questions. If Courtney we'll get a copy of those questions, I'll try to answer them, go through them and take the questions that I know folks may have and address those on the forum as well. We didn't have time to get to all the questions. So I want to thank you again for your time today. Stay safe out there. You guys are doing yeoman's work, and if nobody calls you heroes, I will definitely say you're the most heroic people that I know. So hats off to you guys. Have a great weekend, and we'll talk to you next week.